on to our first speaker, who's Data Raman, one of our first-year residents. Is oxygen supplementation routinely required with myocardial infarction? As you all know, most patients that come into the hospital with acute MI, they're all put on oxygen. It's one of the first things they tend to do. And in ACLS, they teach you MONA, right? It's morphine, oxygen, nitroglycerin, and aspirin is supposed to be your initial treatment. So without further ado.
Good afternoon. My name is Data Raman. Today my question asks, is oxygen supplementation routinely required with myocardial infarctions? In order to fully understand this topic, we need to appreciate the role of oxygen from a historical perspective. In the early 1800s, oxygen was deemed a panacea. In the early 20th century, John Haldane published a paper on the therapeutic administration of oxygen, which was considered a fundamental baseline for much of the uses of oxygen in treatments today. Oxygen use in World War I was administered to soldiers to help in survival in acute gas poisoning, and much of the obstacles to oxygen administration at the time still remain troublesome in treatments today. In the late 1900s, the role of oxygen was studied more carefully, and small randomized clinical trials began to demonstrate that intermittent oxygen treatment caused arterial hypoxemia. As we fast forward to the 21st century, oxygen is used commonly by first responders in most emergency situations, part of resuscitation, anaphylaxis, trauma, or seizure. It is important to review the guidelines from the AHA and the ACC. The 2004 AHA-ACC STEMI guidelines recommend that oxygen be administered to hypoxemic STEMI patients with oxygen saturation less than 90%, and furthermore, that it is reasonable to administer supplemental oxygen to all patients during the first 6 hours. The 2012 AHA unstable angina or NSTEMI recommendations are for supplemental oxygen with an arterial sat less than 90% and respiratory distress or other high-risk factors for hypoxemia. One of the earliest studies to clinically investigate the role of oxygen was by Steele over 100 years ago, in which he first describes the use of oxygen to relieve angina pectoris. And 50 years later, Rusek and colleagues observed that 100% oxygen may actually be contraindicated in patients with myocardial infarction or angina pectoris, and furthermore, that the indiscriminate use of oxygen may cause more harm than good. Studies in the 1960s demonstrated that supplemental oxygen did not increase oxygen transport in patients with arterial oxygen sats greater than 90% because of reductions in the cardiac output in excess of increases in oxygen content. Additionally, it was noted that hypoxia did not affect the availability of oxygen for myocardial metabolism until the oxygen saturation fell below 50%. Before 2015, there were only small population randomized controlled trials that studied the use of oxygen versus air. Rawlis and Kenmore studied the outcomes of oxygen use in pre-vascularization era. MIs were not confirmed in all of these study participants. The conclusion from this study showed that there was no difference in analgesic use between groups with supplemental oxygen use versus air, and additionally that patients in the oxygen group had higher serum aspartate aminotransferase levels and greater incidence in sinus tachycardia. Wilson and Chainer also studied patients with unconfirmed MIs, and the outcomes in this study showed that there was no difference in ST segment change between the oxygen group versus the air group. As these were small population studies, no solid conclusions were able to be drawn. We are all familiar with the idea that ROS are products of normal oxygen metabolism. Studies suggest that oxygen decreases the coronary sinus blood flow in both healthy subjects and patients with coronary artery disease, an effect that was attributed to increased LV coronary resistance. Furthermore, vascular tone is directly related to oxygen levels, whereas oxygen therapy decreases the coronary blood flow and hypoxia elevates it. This image helps to refresh the understanding of the harmful roles that reactive oxygen species may play by triggering arrhythmia, vasoconstriction in the arteries, and downstream effects of ischemia or tissue injury. As mentioned before, many of the studies evaluating the role of oxygen were performed on small populations. There was a true need for a larger population study. This brings me to the AVOID trial, the air versus oxygen in myocardial infarction, which was performed in Australia and published in May 2015. The purpose of this study was to determine whether withholding routine supplemental oxygen therapy in patients with acute ST elevation MI but without hypoxia prior to reperfusion decreases myocardial infarct size. This was a multi-center prospective randomized control trial in which 638 patients were enrolled with acute ST elevation MI of less than 12-hour duration and randomized into 2 groups in the pre-hospital setting. One group received oxygen, 8 liters per minute, and the other group no supplemental oxygen unless the oxygen fell below 94%. Patients in both arms of the study proceeded with primary PCI, and the cardiac enzymes were studied, and patients were followed up in 6 months post-PCI. The primary endpoint data analyzed cardiac troponins and creatinine kinase. The data from the study indicated that the mean peak troponin was similar in both groups, but there was a 27% increase in the creatinine compared with the patients breathing room air. This suggests increased myocardial injury in those delivered oxygen. The data here is from the clinical endpoints and comparing the outcomes at 6 months follow-up using cardiac MRI imaging. In the oxygen group, there was an increase in the rate in-hospital recurrent MIs and cardiac arrhythmias. Most notably in the oxygen group, there was a larger infarct size at 6 months. However, at 6-month follow-up, the rate of adverse outcomes did not differ greatly between the 2 groups. The most recent study on this subject was published in the New England Journal by researchers in Sweden titled Oxygen Therapy in Suspected Acute Myocardial Infarction. The study highlighted that much of the rationale behind oxygen therapy and treatment of myocardial ischemia is limited to experimental lab data and small clinical studies. The aim of this study was to evaluate the effect of oxygen therapy on all-cause mortality at 1 year among patients with suspected MI who did not have hypoxemia at baseline. They acknowledged the AVOID trial as well as the Cochrane report in 2016, which did not show any evidence supporting the routine use of oxygen in the treatment of patients with MI. This was a registry-based randomized clinical trial in which routine supplemental oxygen therapy was compared to ambient air in the treatment of patients with suspected MI who did not have hypoxemia at baseline. 6,629 patients were randomized into 2 groups, the oxygen group in which the patients received 6 liters per minute for 6 to 12 hours delivered through an open face mask versus an ambient air group. Here, the primary endpoint was death from any cause days after randomization that was assessed in the intention to treat population. The data here is from the Kaplan-Meier curve, which indicates similar mortality in those with ambient air versus oxygen treatment. The secondary endpoints included death from any cause within 30 days after randomization and rehospitalization with myocardial infarction, the results of which between both arms are very similar, as you can see here. The conclusion was there was no beneficial effect of oxygen treatment with respect to all-cause mortality at 1 year. In summary, oxygen therapy is appropriate in hypoxemic patients with complicated MI. It is important to recognize that oxygen is a drug with possible significant side effects. And as we have thus discussed, on balance, experimental evidence does not support the notion that routine oxygen therapy provides benefit for reducing MI size, improving hemodynamics, or alleviating symptoms. 2 large clinical studies have highlighted the need for reevaluation of oxygen therapy. Larger clinical trials are also needed to evaluate the role of oxygen and outcomes in patients with stroke. A pilot study similarly evaluated stroke patients in which one arm received 2 liters of nasal cannula of oxygen for patients less than 93% and a control group. The findings from this indicated that supplemental oxygen given 72 hours after stroke is safe, but does not largely affect on any measure in the level of disability and outcomes. Lastly, oxygen is safe and cheap treatment option and is available in very small hospitals and in the pre-hospital setting. In patients that are normoxic, small treatment changes can have significant long-term treatment outcomes, and for this we should be vigilant treating individually and not one and the same. So I ask you, should we avoid oxygen or should we break up with Mona? I'll leave that for you to answer. Thanks.
Stay up here. Question is it a myth? Oxygen supplementation should be given to all hospitalized patients with acute MI. Is this the end of Mona? I don't know. Are there other comments?
How did they come up with that 94% saturation? That's not usually where I think about people being hypoxic.
I have no idea. Do you know? I think that dark-skinned people, the pulse oximetry is less reliable, and usually the cutoff, like in African Americans, we usually would use a higher cutoff of like 94 rather than a lot of times we use 92. And the 92 is kind of a fudge factor also. It's really, people are more worried about it dipping below 90. I don't know, Jeff, do you have any comments on that? So my guess is for a protocol, they didn't want to, they just basically just put everybody, that was less than 94.
Was there anywhere that said it actually is harmful to use supplemental oxygen? I didn't quite get that take, but it seemed like they were all sort of non-significant differences. Was it ever thought to be harmful? There was that ischemia, myocardial ischemia, but was there any outcome or studies that showed there was actually harm in it?
The AVOID trial actually looked at infarct sizes at 6 months, and it showed a 12% increase in infarct size in patients that had oxygen supplementation. I think that was the most concrete.
Well, also there was, I think in the last trial, there was the most recent trial, I don't remember the name of it, the one in the New England Journal, showed that they had increased recurrent MIs in the hospital in that group. That was a significant difference. So it could potentially be harmful, yeah. And there's clinical and experimental evidence. There's experimental evidence of potential mechanisms, which Dea went over at the beginning with free radicals and formation and reactive oxygen species and its effects on coronary circulation. Okay, so we shall vote. How many feel that this is not a myth, that we should just, all patients with acute MI should be getting oxygen routinely? You do? Really? Have you been listening, or are you just on your phone? All right. So we have one thinks that we should keep doing what we've been doing for the last 117 years. Pardon? You're with the. Yeah, there's nothing wrong with the old guys. How many think it's plausible that we should keep doing this? How many think that this is busted, that this is really just not something we should be doing routinely? Okay. Everybody's waiting for it.